As we wait for our next speaker to join in, I will just introduce him. Shashvat Desai is also a close friend of ours. So he will be speaking on evolving devices, techniques, and concepts of MT.
Hello everyone, I am Shashvat Desai. Thank you for giving me this opportunity to speak with all of you, and thank you Dr. Das and everyone in Kolkata. Excited to be here and looking forward to a fruitful discussion. I wanted to talk about the evolution in mechanical thrombectomy technology and particularly focus on devices which are now being made to democratize access to mechanical thrombectomy for stroke. And I will move ahead with my slides. We know that stroke, as everyone in this audience is very well aware, that it's a very, very common disease. But to just give a few brief idea, every year in the world we see 14 million strokes, which is about 1.4 crore strokes every year in the world. And 3.5 million of them, or 35 lakh of them, actually have large vessel occlusion. And it costs the global economy $2 trillion every year, which is half of India's GDP. This is what it costs the global economy every year. And so the point I'm trying to make is that it's a very common disease, it's a severe disease, and has huge socioeconomic implications. This is a quick video of a stroke patient who has a left-sided paralysis. She's hemiplegic. She was treated 5 years ago at our center. NIH stroke scale score is 14. As you can see, the right side is normal, left side is completely paralyzed. And I'm going to use this case as an anchor to talk more about devices which we have today. But dialing back into some history, one of the first known cases of performing any kind of intra-arterial treatment to identify occlusion and successfully trying to open it up was in 1983 by Zoomer, Hack, and Ringelstein. And if you think about this, the first intra-arterial or endovascular therapy to open up a blocked artery in the brain was attempted before it was attempted for the heart. But then somehow there was a long gap where stroke treatment or interventional stroke treatment did not evolve. But cardiology has really, exploded and took the front seat for a long time. But this all changed in 2013. In 2013, we undertook a large-scale trial called the IMS-3 trial, which enrolled patients and randomized them into thrombolysis versus thrombolysis plus endovascular therapy. And this actually set the ground for the next generation of trials as well. Unfortunately, the IMS-3 trial was negative, and it showed no benefit of endovascular therapy plus thrombolysis when compared to thrombolysis alone. And there are many reasons why the trial did not show benefit of endovascular therapy. But one of the reasons, the important reasons, was the efficacy of the devices used to perform endovascular therapy at that time. And this trial enrolled over a long period of time, from 2006 to 2013. And while this trial was enrolling, in the background, technology was, of course, also becoming better. But a large majority of patients treated in the IMS-3 trial were exposed to, as we could say, first generation thrombectomy technology, which was not as good as what we have right now. And by not as good, I mean they could not open up the artery as consistently as we can do it right now. Also, they are a very high rate of complications. And if you look at the graph on the bottom right, you can see how technology has evolved from intraarterial catheter mediated intraarterial thrombolysis to use of ultrasound to use of a coil-like device called the MERCI device in 2005. Then advancing further into aspiration catheters, and just after the IMS3 or towards the tail end of IMS3, we started seeing modern devices like stent retrievers. And the stent retrievers, when they were introduced, they really changed the game. To give you a brief idea, the MERCI device in this case series was able to completely open up the artery only in 24% of patients, while the solitaire device was able to open it up in more than 60% of patients. So that's a more than twofold increase in terms of recanalization. And based on the new technology we had, another set of trials were done, which are considered the landmark trials in mechanical thrombectomy, and most of them were published in 2015. And all of them showed consistent benefit for endovascular therapy when compared to medical management alone. And this was the watershed moment in acute interventional stroke treatment, where before 2015, we had no class 1 data to show benefit of thrombectomy. And after 2015, we have only started expanding our indications and showing more benefit. A large part of this success can be attributed to better technology, better devices. And I want to go back to that patient I showed you earlier who had left hemiplegia, and she had a right M1 occlusion. And this is the image of showing the right M1 occlusion. For this patient, a combined technique was employed using an aspiration catheter and stent retriever. And you can see that after first pass, the M1 is open. And good. 2 hours after the procedure, the patient had phenomenal improvement. Okay. And an NIH stroke scale score for this patient went from 14 to 2. And as you can see, the power has returned in the left side of the body as well. This is a classic case of effective technology, safe technology, complete reperfusion, and ultra early function improvement. This is almost always possible due to better technology what we have today as compared to what we had before 2015. And if we look at what's been happening between 2015 and now from the clinical end, it's important because it has implications for devices. In 2015, we showed that endovascular therapy works in the early time window, 5 trials. In 2018, we extended them into 24 hours with the DAWN and DIFFUSE 3 trial that expanded the patient population altogether. In 2023, the 2 Chinese trials showed that opening up basilar arteries also shows benefit, early and late window. The Boucher trial was done in China for late window. And recently, 2 years ago, we saw 5 randomized controlled trials showing benefit not only for aspect 6 or more, but even for large core strokes. All 5 showed substantial benefit. Only recently, we have seen that in case of MEVOs or median vessel occlusion and distal vessel occlusion, where we have not seen benefit of endovascular therapy. I will talk more about that towards the end, and we can have a discussion about it. But the key points to take away from the previous slides are that endovascular therapy failed previously because of lack of high-quality recanalization. Endovascular therapy and the trial succeeded because we had better devices to treat patients. Dialing back into the natural history of large vessel occlusion stroke patients, I think is important because it informs us what we need to do next. So if we assume we have 100 large vessel occlusion stroke patients, 100 M1 acute occlusions, what is their natural history if we don't do anything for these patients? About 15 to 20% of patients will eventually improve undergo self-recanalization, auto-recanalization, and have a independent functional outcome. A large majority of patients would remain paralyzed, remain dependent, or bedbound. And about 15 to 20% of patients will experience mortality within the first 90 days after the largest occlusion stroke. If you add endovascular thrombectomy to these patients, there's a substantial benefit. And what we see is that approximately half or slightly more than half of patients experience functional independence. And we can reduce mortality post-thrombectomy as well, especially in large bore patients. So if you compare to the natural history, endovascular thrombectomy has a substantial benefit. But the point I want to make is don't look at the patients in green, look at the patients in yellow and red. And despite high quality recanalization, despite class 1A evidence, 40 to 50% of patients after endovascular thrombectomy still either die or remain disabled. So while our technology has really improved over the last 10, 15 years, there is still a lot of scope for improvement. We can still do better. Even today, the rate of first pass effect, which is complete recanalization after one thrombectomy pass, is under 50%. We have to do 2 or 3 passes on an average to achieve TICI 2B, 2C recanalization. So there is a lot of ground to cover. And another problem in the interventional stroke world is that, of course, we need better devices, but this treatment is very new. And this is a great New York Times article saying that revolutionary stroke treatment, that is thrombectomy, will save millions of lives. There is no question about that. But it says eventually, and this word eventually is important because we have shown in 2023 that across the world, global access to mechanical thrombectomy is very, very low. For every 100 LBO strokes, only 3 patients end up getting mechanical thrombectomy. 97 do not. So key points are, despite a very powerful treatment, 50% of patients do not achieve functional independence. And despite us having a powerful scientifically proven treatment, less than 3% of patients actually getting treatment. So what this means is that our focus should be towards building better devices, better techniques to better recanalize patients, and making affordable devices so it can reach more patients. So these are the 2 main goals: better devices, affordable devices. And I'm going to give a very quick flavor about what better devices could look like, especially what's happening in the last 3 to 4 years. We know that an average or a typical aspiration catheter has a non-angulated or flat tip at the distal end, something like this. Over the last 4 or 5 years, we have seen introduction of bevel tip or angulated tip aspiration catheters, and these have potentially or theoretically some inherent advantages. Because of the angulated tip, you may be able to overcome the ledge effect when you go from the internal carotid via the ophthalmic segment and have better trackability and be able to reach the clot more frequently and more successfully. Additionally, as compared to a flat distal tip, if you have an angulated distal tip, in theory, you have a larger area which can aspirate the clot. And there is some clinical data to show that this may improve recanalization rates. A new trend these days is large bore aspiration catheters. We used to consider 070 inch ID as large bore. Now the trend is to go towards super large bore aspiration catheters. The 3 catheters currently available which come to mind when we think about super large bore aspiration catheters are the Zoom 88, the Millipede 88, and the Red 78. The inner diameter of these aspiration catheters is substantially large, ranging from 0.078 to 0.088 inch. There's a new catheter we tried recently. It has a 0.092 inner diameter, and the concept is that the larger we go in terms of aspiration catheter, the more clot we'll be able to remove in one go. This has, of course, not been shown or proven in a randomized controlled trial, but empirical data and anecdotal evidence from people who are using it is very promising. And I'm sure we'll see how it evolves further. In terms of better stent retrievers, on an average, a stent retriever, as you know, it's sheathed into a microcatheter and delivered to the clot. And when we remove the sheet of the microcatheter, the stent retriever expands on its own because of the alloy has a shape memory alloy effect, and then it engulfs the clot. There have been some newer concepts which have been introduced wherein this stent retriever made by an Israeli company called Rapid Medical, you have an actuator at the proximal end, and if you move it, you can expand the stent using your actuator control. So it's a different way the stent retriever works. We have used this. It is not shown to be better than existing stent retrievers, but it's how we are seeing an evolution happening at the stent retriever end as well. In terms of technique, one of the new emerging techniques is to use more than one stent retriever up front. Normally, we use just one stent retriever with or without aspiration to perform thrombectomy. This was a study called Twin2Win, was led by Dr. Mark Rebo, who was in Kolkata for ILSC last year. And this study was published late last year, and they showed that using two stent retrievers, either in two different M2 branches or in the M1 and the A1, leads to higher first pass effect. Most recently, Dr. Das, has used three stent retrievers, and I think the field is moving towards, using all the tools at our disposal to improve decanalization rates. So this is an emerging technique. While we are focusing on better devices and techniques, the question which keeps me up at night is, what about affordable devices? And also, one factor is important to know is all the devices and techniques we have right now have largely been researched and developed in the Western populations, not in Asian populations or in Indian populations. And we know that there is fundamental difference in pathophysiology, etiology, rates of intracranial athero, and also clot morphology in different ethnicities. So we need to build devices which can work well across the spectrum, and also they need to be affordable. And towards that end, I want to share a story of Gravity Medical Technology, which is hosting, as of now, the grassroots trial. CMRI is a center for the grassroots trial in India, along with 9 other hospitals. And we have developed two devices. One is the Supernova device, which is a stent retriever, and another is the aspiration catheter. They both will be available in India very soon. But I quickly want to walk through the journey of how we develop those devices, which are cost flexible, and also I want to show some data as to how they're doing right now when they're being used. Cost flexible device development is not easy. There is a lot which goes into device development required to make research and development efficient. You need to do the research in geographies where it's required the most. You need to achieve economies of scale, and you need to have first pass effect in as many patients as you can, because the number of devices being used per patient goes down. And this graph I like a lot, and I've shown it before many times. On the y-axis is the cost, on the x-axis is the performance. I can spend a lot of money and have little increase in performance, and those would be called delight factors. I showed you a stent retriever where you can use an actuator to control how the stent opens up. It would take a lot more to build a device like that, but I don't think it has that much impact on the device's performance. What we really need is to spend appropriate amount of resources, but have huge improvement in the performance of the device, such as efficacy against tough clots, efficacy against fibrin-rich clots, which are more common in Asian populations, Indian populations. So we need to focus on value-based design features. Of course, stent retrieval design itself is important. The stent retriever which we have built, we have data from preclinical models that it is as good as it works against red clots as other designs, but it works better against white clots as compared to other designs. So it's a one size, one design fits all kind of an approach. To go into a few design characteristics of our stent retriever, which we have built, is that we have adjusted the strut of the stent, its ratio, in a way that it can engage the tough clot far more and far better than anything else. If you look at this drawing on the right, on the top row, you will see that data comes from Solitaire, and on the bottom, you will see the data from Supernova. You can see how the strut in the cross section has a different dimension, and hence the penetration into the clot is much more with the Supernova device, which actually enables it to capture tougher clots much better than other devices. Another feature is when you look at any average stent retriever, the radial force with which it opens up is same across the stent, across the length of the stent. If you can see the three things towards the right, retrieval, Solitaire, and embotrap. Proximal, middle, distal, same radial force. If you look at Supernova, proximally and distally, there is lower radial force, but in the middle segment, there is higher radial force. So at the clot engaging segment, there is more efficacy, while the overall stent is more flexible. We perform significant preclinical testing as well to show benefit in all types of clots. We work very closely with the University of Amsterdam to do virtual testing of a stent in a virtual stroke patient, and we could essentially test thousands of designs before actually making the design that actually works the best. We've shown in preclinical models and animal models better efficacy with red clot and white clot. I'm going to skip through animal testing for the interest of time. Human testing is very important to us. We are doing the grassroots trial in India. The device is already approved in Thailand, Dominican Republic, and Pakistan. I wanted to show some cases from the grassroots trial. This was the first case in the grassroots clinical trial where the aspiration catheter could not be tracked up beyond the carotid. So the stent retriever was the only device used, the Supernova stent. In one pass, we could open up the internal carotid. In the second pass, we could open up the M1 artery. This was the first case done in Karachi in 2023. I wanted to show some challenging cases which we have been able to do in the setting of intracranial lateral sclerosis, and we are receiving very good feedback from doctors in Thailand and in India. I'm going to skip through this slide, and I really want to focus on the grassroots trial in India, which is using the Supernova device as the investigational device. Since we enrolled the first patient in August 15th, 2024, over the last 7 months, we have enrolled 28 patients already. We are just 2 patients shy of completing the device trial in India, and we should be having CDSU approval within the next 4 to 6 weeks. And then the device would be available in India for commercial use, and it would be substantially more affordable than any device we have in India right now. And I wanted to go to the slide which I really want to show is this one, that We have now used our device in 8 countries. We have treated more than 200 patients. India market approval is expected very soon, and we hope to get this device into hands of all doctors in India. Less than 5,000 thrombectomies in the same year for a very similar population of countries. So that's something which we have a long road to cover, but I think one of the steps, along with what everything the Stroke Prabaho Foundation is doing, we also need to push for affordable devices, reimbursement, and other technologies to improve access to treatment. I'm just going to stop here.